Hi everyone, and thank you for joining us today for part 2 of our 3-part webinar on finding the root cause of the medically unexplained. Before we kick off with today's session, just a quick summary of our series so far. So we're taking a great interest in what the NHS have termed medically unexplained symptoms. According to the NHS, about 1 in 4 people who see a GP in the UK have physically unexplained symptoms. This is probably a stat that a lot of people are not surprised with these days. But the fact that GPs are currently unable to access the resources that people need to help find a condition, we know doesn't mean that there's nothing to be done to help. So our webinar series is, as it says in the title, all about finding the root cause of the medically unexplained, and we're here to take the experience of reputable fellow health professionals like our host today to explore client case studies and innovative treatment processes that go beyond symptom management. So today's session will be all about irritable bowel syndrome, and I'm pleased to be able to introduce you a former Genova Diagnostics employee, Jessica O'Dwyer. So Jess has truly paved her way within the functional health space. She started her career with us as a medical education specialist, collaborating with leading experts in functional health. Her expertise have further flourished as she took on roles that oversaw the implementation of wellness initiatives for financial institutions such as Barclays and UBS. Her research contributions are exemplified by her involvement with the Nutritional Psychiatry Research Team at the Food for Mood Centre at Deakin University in Australia, and it was there that she focused on the intricate gut-brain connection, further fueling her passion for uncovering the complex link between the gut microbiome and ME in CFS. So with such a glowing resume, we're really glad to have her back with us and presenting today. We will be taking questions at the end of the session, but everything will be anonymous, so please just drop everything in the Q&A box and we'll get around to it at the end. So without further ado, welcome Jess. Hello.
Thank you very much. So we're going to cover irritable bowel syndrome today. And as Amelia kindly introduced me, so just a little bit about me. I've done a master's in personalized nutrition. I'm a functional certified practitioner. I've specialized in gut and endocrine disorders and ME/CFS. So I've done research in the field of ME/CFS and gut-brain connection. And I was a previous medical education specialist at Genova Diagnostics, meaning I have interpreted and reviewed many stool test results. So today we're going to go into the epidemiology of IBS. We're going to look at the Rome 4 criteria, diagnostic criteria. We're going to look at some of the conventional medical treatments for IBS. We're going to look at some of the underlying causes, and we're going to look at the pathophysiological mechanisms. And then I'm going to go into a little bit more in those mechanisms associated with the gut, immune, nervous, endocrine system. And then I'm going to show you a case study. So starting with the epidemiology of IBS, it is a chronic functional disorder of the gastrointestinal system. Patients experience abdominal pain, altered bowel movements, manifesting as either predominantly diarrhea, constipation, or mixture. There is no definitive investigation or biomarker for IBS, so it's clinically diagnosed. The earliest descriptions of IBS date back to the 19th and 20th centuries. And IBS diagnosis involved ruling out malignant, inflammatory, or infectious diseases after comprehensive investigation and extensive unsuccessful surgeries. In the 1970s, IBS was frequently misdiagnosed and poorly understood, with issues of unnecessary and unsuccessful surgeries. The Rome 4 criteria definition is irritable bowel syndrome is a chronic, relapsing, and often debilitating disorder of the gut-brain interaction. Its typical clinical features are abdominal pain associated with a change in stool form and/or frequency, which may be related to defecation and associated with bloating. Now, they state that the pathophysiology of IBS is not fully understood, but likely to be multifactorial, involving biological, psychological, and social factors. Now, the prevalence of IBS, this 2012 study looked at the demographic of those diagnosed with IBS is mainly across kind of industrial countries, more westernized type countries. We can see here that it ranges between 9 to 23% of the population across the world. And IBS on quality of life is 1.5 times more prevalent in women than in men, and more common in lower socioeconomic groups, and usually diagnosed in patients under 50 years of age. IBS patients visit doctors more frequently, they undergo more diagnostic tests, they use more medications, miss more work days, have lower work productivity, are hospitalized more often, and incur higher overall direct costs than non-IBS patients. Now, resource use is highest among patients with severe symptoms and poor health-related quality of life. And it is stated that treatment should be tailored to the severity of each patient's symptoms on their health-related quality of life impact. Now, this is quite an interesting study. We know that our microbiome is shrinking in the Homo sapiens. We can see here in comparison to other species. If we look at the diagnoses of IBS, so a lot of our clients are experiencing these symptoms for quite many years before they generally come and see us. But when they get the diagnosis, this is just what to expect that our clients have gone through. It should be diagnosed in the absence of alarm symptoms or signs if any of the following symptoms have been present for 6 months, and this is the abdominal pain, the bloating, the change in bowel habit. And it's generally the diagnosis is made by primary care if the abdominal pain and discomfort has been present for the 6 months at least and is either relieved by defecation or associated with altered bowel frequency, stool form, and is accompanied by 2 of these symptoms like altered stool passage, the abdominal bloating, worse by eating, and passage of mucus. They also use the Bristol Stool Form Scale to differentiate the type of IBS. So mostly diarrhea and abdominal discomfort is IBS-D, mostly constipation and abdominal discomfort is IBS-C, and then alternating loose and constipation with abdominal discomfort is the IBS-M, and then there's the undefined subtype IBS-U where symptoms vary. Now, a lot of our clients might come to us have already tried a lot of these treatments with their doctors, but just to note, over-the-counter probiotic supplements are continuing to be recommended for at least 12 weeks and discontinue if symptoms don't improve. What we see in the research is this only helps about 1 in 7 patients, and they also try medications like antispasmodics, PPIs, antacids, antidepressants, and then medication to reduce the bowel frequency like Imodium or 5-HT3 receptor antagonists. They've also been recommended psychological therapies, and again, that tends to help 1 in 4 patients. This review by Ben Brown, quite an interesting review, 2019, he states that significant shortcomings in irritable bowel syndrome diagnosis and treatment may arise from IBS being an umbrella diagnosis that clusters several underlying identifiable and treatable causes for the same symptom presentation into one classification. He goes on then to mention some of the underlying causes of IBS. And we can see here we've got lifestyle, environmental factors, we have nutritional factors and functional imbalances. Now we'll go through some of these in the case studies and we'll go through some of these mechanisms, but we can see quite commonly that stress has been linked to IBS, but disruptions in circadian rhythm, anyone that works in night shifts, physical inactivity, but over here in nutritional factors, carbohydrate intolerance, lactose intolerance, food hypersensitivity, ones that we see non-celiac gluten sensitivity, nickel-related intestinal mucotitis, a vitamin D deficiency, and then over in the functional imbalances, some of the underlying causes, exocrine, pancreatic insufficiency, low-grade inflammation, intestinal permeability, bile acid diarrhea, chronic constipation, dysbiosis, small intestinal bacteria overgrowth, and parasitic infections. Now, Dr. Karazian mentioned that many gastrointestinal conditions fail to resolve because the treatment model ignores the principles of clinical hierarchy. In addition to understanding the clinical hierarchy of gastrointestinal system, you must find the mechanism of action and prognosis. So looking at some of these pathophysiological mechanisms, it's our job as practitioners to use some of the functional testing that we have access to now to really understand what pathophysiological mechanisms we could be working with our IBS clients. Are we looking at the gut-brain axis? Are we looking at motility disorders, intestinal permeability, psychological factors, food sensitivities and intolerances, genetic and epigenetic factors, so really looking at the environment, neurotransmitter imbalances, visceral hypersensitivity, and gut microbiota imbalance. Now, a lot of our clients can present with multiple of these mechanisms, especially around visceral hypersensitivity, motility disorders, gut-brain, and the environment and psychological. So if we were looking at this clinical hierarchy, it's very important that these functions of the digestive system are working, because this has a downstream effect to the bowels. So when we start with digestion, swallowing, are they chewing their food properly? Is enough saliva going into the food to stimulate our central nervous system, our vagus nerve, intestinal motility and proper valve control, the saliva production, the production of hydrochloric acid and pancreatic enzymes and bile, normal gallbladder contraction, proper assimilation of nutrients by the microvilli, and then maintaining electrolyte balance and hydration in the colon. We also want to establish, is there healthy immune responses to food proteins? Is there normal intestinal tight junctions, transcellular and paracellular? Is there non-active dendritic cells, T cells, Kupffer cells, highly functional regulatory T cells, normal secretory IgA levels, and then the microbiome health, the diversity of a healthy microbiome, and then the absence of pathogens. So this is important to understand when we're doing our case history, to really make sure we're evaluating each of the symptoms in these areas so that we can understand their clinical hierarchy when it comes to digestion. One that I commonly see kind of overlooked is, are they producing enough saliva? Are they reporting dry mouth? Are they got any gum, dental issues? Really diving into those questions in your intake, because that will establish whether they are getting that appropriate amount of swallowing and the initial process of the digestive system. So if we were to look at some of these gut, immune, nervous, and endocrine system mechanisms, so that I want to just touch on a few of them. Now, there are many, many different mechanisms, but we're going to look at it through the lens of the gut, immune, nervous, and endocrine system. So if we start with the gut-brain axis, so the vagus nerve communication is critical here. So the vagus nerve is a major part of the parasympathetic nervous system. It facilitates the communication between the gut and the brain, allowing for a bidirectional signaling transmission. Now, we also rely on neurotransmitters. The gut bacteria produce and respond to neurotransmitters like serotonin, GABA, dopamine, influencing mood, cognition, and behavior. The neuroendocrine signaling, then, the gut microbiome affects the release of neuroactive substances impacting hormonal and neuroendocrine responses related to stress, anxiety, mood, and regulation. Now, that should hopefully help understand when we're thinking of what the Roan criteria even definition was, a functional disorder of the gut-brain connection. So these mechanisms are very important to understand when we're evaluating our client case. If we look at it through the gut immune axis, the microbial regulation of the immune response, so the gut microbes interact with our immune system to develop and regulate immune responses. So this helps in maintaining immune tolerance and preventing inappropriate inflammatory reactions. We also toll-like receptors, so the gut bacteria stimulate toll-like receptors, playing a role in immune surveillance and response to potential threats essential for maintaining homeostasis. Now, the gut endocrine axis. So when we're looking at hormonal regulation, so the gut microbiome influences the secretion and metabolism of hormones like insulin, our GLP-1, and our PYY, so peptide YY, affecting metabolic regulation, appetite control, and energy balance. We often see with our IBS clients that their appetite fluctuates, their energy is certainly compromised, but also short chain fatty acid production, things like butyrate you might be quite familiar of, which we will see in our case study. The gut bacteria ferments certain fibers to produce these short chain fatty acids, which influence things like hormonal secretion, particularly impacting things like insulin sensitivity and glucose metabolism. Now, another important area is the influence on neurotransmitters and neuromodulators. So serotonin production, up to 90% of serotonin is actually produced in the gut, and our gut microbes aid in serotonin production and the neurotransmitter involved in our mood, appetite, and gastrointestinal function. Around 10% of serotonin is measured in the brain, but the gut-brain hormones, the bacteria influence the secretion of hormones like ghrelin and leptin, which regulate hunger and satiety signals. I want to touch on small intestinal bacteria overgrowth. So up to 78% of patients with IBS present with small intestine bacteria overgrowth. Now, this is a condition characterized by abnormal increase in the number and alteration in the type of bacteria present in the small intestine. Now, for those that work with SIBO, you know that it's quite a complex condition, and without addressing the root cause of SIBO, it's quite difficult to get the client into a remission. Symptoms include things like bloating, abdominal pain, diarrhea, constipation, but malabsorption, which can lead to nutritional deficiencies. Now, this is quite complex if we're working with a malabsorption syndrome. So if a client is presenting with these types of symptoms, it's important to get the appropriate investigation. However, the connection between SIBO and IBS is controversial because of several factors like clinical diagnostic methods, the breath testing, have significant reliability and accuracy limitations. There is a lack of strong data showing that eliminating SIBO leads to long-term clinical improvement, and the evidence suggests that the effectiveness of antibiotic treatment might not be related to the presence of SIBO, but can be due to the non-antibiotic mechanisms. There's quite an interesting two papers referenced down below if you want to look into it a little bit further. Now, I'm going to take you through a case study, and I really do welcome questions here. This case, I'm a little bit ahead of time, so that's good. I thought I'd be a little bit delayed today because there's so much to unpack when it comes to IBS and so much that we can go into. So with this case study, it was quite an interesting one in the fact that she had limited finances, so we really had to be strategic. And she struggled quite a lot before she saw me. So she'd been to multiple doctors and she'd had colonoscopies that came back and normal. So this was a young 30-year-old female, 64 kg, diagnosed with IBS. She was also coming to see me for allergies. She was an allergy to dust and pollen. She had IBS that was ongoing for 10 years, but she also questioned PCOS due to family history. The medications that she had been on before seeing me were antihistamines, and she had a history of NSAIDs. Now, her presenting symptoms, she stated that, these are her own words, approximately once every 2 months, I would experience what feels like the equivalent of labor pains with diarrhea. She was presenting with headaches, hair thinning, oily hair, dandruff, sinusitis, rhinitis, general congestion, psoriasis, which wasn't officially diagnosed, fluctuating mood. She was easily distracted, bloated, heartburn, indigestion, flatulence, diarrhea, breast tenderness, irritability, and water retention. Now, her family history, there was grandparents with cancer, type 2 diabetes, high blood pressure, bypasses. Her parents had high blood pressure and were overweight, and she had a sister who had PCOS. Now, Paula was off the back of occupational burnout, which forced her to leave her career in marketing. She was exposed to recreational drugs, increased alcohol consumption, and a high sugar diet. She had reoccurring kidney infections as a child, which led to multiple antibiotics. She had an awareness around which foods triggered her. So in her own words, she said she used to have an intolerance to eggs accompanied by stomach cramps, but haven't experienced this for years. She would get a rash on her chest after certain coffee. She would get indigestion after fatty foods, and coffee would sometimes make her go to the toilet, get quite sick after alcohol, and when she'd eat fruit, she would get upset stomach and diarrhea. She also had stomach upset from foreign travel. Now, her diet, it's always quite interesting when you ask a client the foods they crave and their favorite foods. You can tell a lot about a client's health when you ask those two questions. So she said she craves salty foods and water dense like fruit. Her favorite foods were things like tuna mayo, ramens, tomatoes, sushi, fried chicken, McDonald's, and pasta dishes. So that can tell you a lot about someone's microbiome already. Now, on evaluation of her diet, it was low in protein. She wasn't even meeting the 0.8 grams per kg of body weight to prevent disease. Her hydration was low, so based on her weight, she should have been drinking 2.240 litres of water, and she was just about meeting 1.5 litre, and that wasn't consistent. She had recently started eating breakfast. She was trying to intermittent fast. She was consuming the most common cross reactors to pollen. So if you remember, she had a pollen and dust allergy. So she was eating foods like apple, apricot, carrot, celery, cherry, coriander, nectarine, parsley, and peach. So if you remember, she said she craves water-dense foods like certain fruits. And these were the fruits that she was eating, because over 50% of people with a birch allergy have cross-reactivity with some fruits and vegetables. So if we, like I said, finances were limited with this case, so we had to be quite strategic with testing. So we ran a GIFX, we couldn't do any add-ons, and we did bloods. So she had high prolactin, FSH, and low vitamin D. So already I'm kind of thinking, okay, should we be investigating PCOS? She had above optimal monocytes, hemoglobin, ferritin, cholesterol, triglycerides, LDL, iron, so I'm thinking inflammation. She had below optimal of folate, T4, HDL, potassium, and calcium. Now, if we look at her GIFX and we just look at the summary page, we can see here we've got inflammation, dysbiosis, metabolic imbalance. Now, I've looked at many of these reports, and I tend to see patterns of clusters of symptoms, and this is what I did my research in. I investigated the gut dysbiotic and the immune-associated dysbiotic pattern in ME/CFS, and I used the GIFX. We had 84 cohort. We could only use 34 because out of the 84, it was retrospective. Out of the 84, only 34 did a GIFX, and I couldn't standardize across all of the other labs. So we looked at 34 individuals that ran a GIFX. And looking at this, I would also take a glance at the borderline high fecal fats and the relevance of that. If you remember her symptoms, she would get urgency after coffee. And with her inflammation, you can see there she's got high secretory IgA, her dysbiosis, she metabolic imbalance, so high beta glucuronidase. Straight away, I'm thinking of her estrabolone, estrogen, in connection to PCOS and her hormones. I should have mentioned that her menstrual cycle, she would cycle maybe every 40 to 50 days. It wasn't as regular. She would get extreme abdominal bloating also around her cycle. And we can see there that there was no infection. So if we look at her breakdown of digestion, absorption, inflammation, immunology, and the gut microbiome metabolites, we can see here at fecal fat is borderline elevated, but it's her long chain triglycerides, her long chain fatty acids, I should say, that are borderline elevated. So I'm thinking, is there a malabsorption here? So IBS is often as a symptom of bile acid malabsorption, and it's more likely with diarrhea subtype. And then I'm also questioning, could we be looking at SIBO here as well? Now, she was more of the diarrhea subtype. We can see here she has increased secretory IgA, although her eosinophil protein X was low, which I was quite surprised about based on her allergies. I was thinking we might see a high eosinophil protein X, as this is an IgE mediated inflammatory marker. But although her fecal secretory IgA was elevated, this could be due to a heightened response to non-infectious stimuli like food sensitivities and allergies. Her beta glucuronidase is quite elevated here. So when we think of beta glucuronidase, when we're breaking down our hormones and toxins, particularly if we think of our estrogens that get metabolized and sent to the gut, beta glucuronidase can deconjugate the molecule and can recirculate these estrogens around the body. So it was important for me to support this area, support the liver, support her glucuronidation pathway, because I feel like this had a connection to her menstrual issues. If we look at her commensal balance, now it's very important to understand here that this is a snapshot. It's looking through a very small window and giving us an idea of what could be going on in the microbiome. But if we see there's a lot of highs here, you can see her microbiome is trending more towards the 5th quintile distribution. So remember, this is looking at a population distribution. Straight away, when I look at this, I know, okay, right, we've got a high westernized diet here, high bacteroidetes. But then I see there's high Faecalibacterium, which is quite a high butyrate producer. And actually, there's evidence there to show that it decreases visceral hypersensitivity in IBS patients. But we don't want too much bacteria. We want a balance of these microbes. She also had the high bifidobacterium, and we know bifidobacterium keeps the pH low, preventing pathogens from overgrowing. But most significantly, we can see she had low Akkermansia. Now, this microbe communicates with our colonocytes, our enterocytes, and lives in the mucus layer and helps to regenerate mucus. But hers is below detectable levels, despite having an abundance of the other species. Now, no real comments here apart from, just a little bit of Klebsiella, but it wasn't, it was at a non-pathogenic growth. Klebsiella has been known to be a hydrogen sulfide gas producer, but with the high bifidobacterium and keeping the pH, and she also had, if we look back as well, she had the high lactobacillus and her firmicutes there. So if we look at, so I'm going to give you a snapshot of over 8 different consultations that we did with this case. So initial steps. First, when we did the initial consultation, I just had to start her off on stabilizing her glycemic response by increasing things like her fiber, cruciferous vegetables, but her protein, I decided to increase it to 1 gram per kg of body weight. And we also wanted to increase her essential fatty acids in the diet, but I did this quite gently because I was suspicious of the fat maldigestion or malabsorption. So we only did this quite gently, but we removed the other quite fatty foods that she was having, the fried chicken, the McDonald's, all those types of foods. And we just did things like flax seeds, we did things like fish. We got more diversity from that sense in terms of her oils that she was using, because she was reliant on vegetable oils and olive oils to cook with. So she was doing her stool test, and when she came back to see me, we then started some of the interventions, but I had to regulate her nervous system first. So we were really working on her gut-brain connection. So I got her doing some things like vagus nerve stimulation, and just some of the gentle stuff like gargling and singing, humming, grounding. We also did emotional freedom tapping, introduced her to those techniques. She struggled to do anything like meditation, so I tried to get her to lean into more guided meditations, or even just focus on breathing, regulating her breath, or even leaning into some creative work, things like artwork she used to do before. Anything that brought her the sense of calm, or that sense that a sense of joy. I try to encourage her, because as we can imagine, working with a lot of these clients, there are so many different techniques that we can use to help support someone's nervous system, or help to recommend certain techniques, but it's not suitable for everyone. So what I generally say to my clients is lean into the things that bring you joy, because that will send the signal to your nervous system that you are okay, and shift you out of that sympathetic response and support the vagus nerve. I got her to reduce high intensity workouts. She was doing about 5 high intensity workouts every morning, and her sleep surprisingly was okay. So these were the main lifestyle interventions we did at the beginning. I got her doing a continuous glucose monitor as well. I really find this is quite helpful for motivation, and really helps the client understand more about blood sugar regulation. So we identified quite a lot of things. We just did the 2 weeks, and we noticed that there were certain foods that really motivated her to stay away from the fried chicken and the McDonald's, and things like pastries and foods like that, and really lean into the more fibrous foods like her non-starchy vegetables and whole grains. Now you'll notice I didn't remove gluten from her diet. I only really removed the foods that were cross-reactive, the high allergen foods to her pollen allergy, and really supported the nervous system and immune response in that angle. Increased her electrolytes, because we really needed to increase her water. I also introduced things like papaya to stimulate the pancreas. Now you noticed in the stool test results that our pancreatic endocrine function looked normal, but because of the potential malabsorption there, we just increased some papaya to kind of stimulate the pancreas. We also added in some gut lining support foods, some mucin supporting foods like the flax seeds, the chia, the aloe vera, kelp, things like figs, marshmallow, and slippery elm teas. And we also brought in some adaptogens. Now, because she was off the back of emotional burnout, now when I say that, I mean she'd been to therapy, she'd left her job, she felt like she was much more connected to her body. She didn't have that kind of derealization or lack of motivation. So I still, at this point, I couldn't do a cortisol test, so I didn't know how her cortisol was functioning. So I just went in with quite gentle adaptogens, and because I was suspicious of PCOS, I didn't go in with any ashwagandha. I just went in with things like L-theanine and passion flower, which she responded quite well. She noticed quite a reduction in her anxiety. I also added in the magnesium glycinate. Now it does help with sleep, but it also helps with calming the nervous system and supports liver. And there's at least, you don't get any diarrhea after magnesium glycinate. As you're aware, I'm sure that there's many different forms of magnesium, and it's more the oxide and the citrate that can lead to supporting bowel movement. So because she was the IBS-D subtype, I just went in with a gentle glycinate. and I just started off with about 200 milligrams. We also increased her vitamin D to 4,000 IUs. If you remember, her vitamin D was low. When she came back after, if we go into the third consultation now, she was starting to know an improvement in her bowel movements, more regular. She had a reduction in her bloating. She really saw a reduction in her allergy type symptoms like the headaches, her energy improved. But it really got me thinking and a bit suspicious around histamine intolerance. I was questioning at this point because I was thinking of her DAO and her brush border enzymes and what could be happening on the gut lining. So because of the family history, I was a little bit suspicious around the cardiovascular disease. Could there be SNPs on her methylation genes? Now, I couldn't test at this point, so I just went in with really gentle methylated B drops so that we can control it to see how she would respond. Because if you remember, her folate was on the low end. So we just started off very slowly with 4 drops under the tongue to see how she'd respond. At this point now, I brought in lipase enzyme to further help with the breakdown of fat. I brought in berberine as an antimicrobial just to help with the dysbiosis. Now, berberine is a bit what's the word I'm looking for? Debated, I should say. Lost my word there. Because berberine can have quite an impact on bifidobacterium and other beneficial microbes. I wouldn't generally go in with it all of the time, but in regards to the blood sugar balancing effect as well, I went in with 250 milligrams twice a day with milk thistle. And we did this quite gently as well. Now, I wanted to make sure that we were encouraging the growth still of the bifidobacterium. But if you remember from her commensal bacteria, she had quite robust levels of bifidobacterium. So I felt like we could handle the berberine, but I also got her to really increase her polyphenol foods that included inulin and phos. Because the polyphenol foods are really what's going to increase things like her akkermansia and keep her bifidobacterium robust, aside from the berberine potentially impacting it. I also brought in apple cider vinegar to help with the breakdown of starch to further accommodate her blood sugar regulation. And we also got in some lactobacillus ramosis post berberine to make sure we encourage the lactobacillus growth. I put in a gut binder called Toxiprevent. This helps to bind particular gases and toxins, but more importantly, histamines. And it helps to alleviate the load on the internal organs, primarily the liver and the kidneys. And to support her glucuronidation pathway, we really got to increase things like sulforaphane, so her cruciferous vegetables. We brought in things like cabbage juice. Now, she didn't like drinking cabbage juice, who does? So we just got it to put it into bases of some sauces. Now, her diet at this point was really great. She was achieving her 1 gram per kg of body weight in protein. She was getting a diverse range of her proteins from plant-based to animal-based. She was having a diverse range of polyphenols. She was getting her non-starchy vegetables in. So I still wanted her to have some grains in her diet as well to keep the diversity of the microbiome and making sure that kind of berberine was helping to reduce the dysbiosis slightly. Now, at this point, we got the GP to run a test to check for PCOS, and she had high testosterone. So we started supporting testosterone, and she did have high estrogens as well and low progesterone. And with the high prolactin and the FSH, we were questioning PCOS. Now, she hadn't had the ultrasound yet at this point, but we started to put in some things to support the high androgens like a saw palmetto complex, because she was really reporting symptoms of PCOS, hair thinning, hirsutism, really increased sex drive, oily hair, the periods, been about 50 days. And when we started to put in the salt palmetto and supporting the androgens after all the work that we did on the microbiome, she noticed quite a difference in her menstrual cycle. It started to normalize. She's now menstruating every 30 days on average. She really saw a reduction in oily skin, even the dandruff on her scalp. She wasn't getting as much hair growth, and she started even noticing a lot of hair regrowth on her head. Now, we were continuing to regulate the nervous system and her lifestyle by keeping up the EFT. She noticed quite a good improvement with EFT. She reduced the HIIT workouts, and we really got the diversity into her diet. Sorry now, I hope there's not some noise. The gardeners decided to mow the lawn, so hopefully that's not disruptive. And so this is a picture of Paula. She's got regular bowel movements. They are consistent. She doesn't have to worry about eating out or going on holidays. She only needs antihistamines in the high allergy season. She saw an overall 80% reduction in usage. Her menstrual cycle is regular, on average 28 to 30 days. That was from the 40 to 50 days. She doesn't experience the rhinitis or the sinus issues. And these are her words: "I'm full of energy and everyone noticed how well I look." Her mood is stable and she has started her own business. Okay, so timing was good. I was worried that we would go over quite a lot today. I would just like to thank you very much, and I really welcome any questions. These are the places where you can find me. You can follow me on socials. My clinic is based in London, but I work with clients globally, and these are my contact details. So thank you very much.
Thank you so much, Jess. That was such an engaging presentation. I mean, as someone who isn't medically trained, it may be stupid of me not to have known this, but I was so surprised at the cross-contamination between the food, fruits and vegetables and pollen. I don't know why that surprised me so much.
Yeah, and not a lot of people know that either, and it can, yeah, really impact their allergies.
Yeah, massively. So as Jess said, we'll now be taking some questions. If you want to just drop them in the Q&A box and we'll get through them. So we had a question come in quite earlier. You discussed adding magnesium into the case study's treatment plan. Could you kind of expand upon maybe the benefits or efficiency of probiotics or other microbiome modulating therapies?
Absolutely. So there are many, so like I went through in, I think it was consultation, it might have been consultation 5, I introduced the Lactobacillus ramosis. So there's quite a lot of evidence around Lactobacillus ramosis in as supporting bowel motility, especially when it comes to IBS. I generally, because I was a little bit suspicious with SIBO in this case, I didn't go in with probiotics early on, because if you saw in the research there, it only helps 1 in 7 cases. And if we're working with SIBO, I wouldn't go in with any broad spectrum probiotics. I would generally only go in with like a lactobacillus and really use the foods to encourage the growth of the bacteria in the microbiome.
Okay, great. And then you mentioned earlier as well about how you were concerned about PCOS symptoms, so you didn't recommend ashwagandha. Could you expand on that as well?
So high dose ashwagandha can increase testosterone, can increase androgen. So I didn't go in with ashwagandha. Now there is generally, say, like the studies show about 2 grams, and I would rarely ever go in with ashwagandha 2 grams. But because finances were limited, I had to be quite strategic with the supplements I recommended as well. So L-theanine is quite cheap, and passion flower is really cheap as well. So I went in with those 2 in that case, and she noticed quite an impact on her anxiety with the L-theanine.
Right, okay. Amazing, thank you. What are some of the key indicators that might help differentiate between IBS D, C, and M in clinical practice?
Rephrase that, say that question again to me.
What are some of the key indicators that might help differentiate between IBS D, IBS C, and in clinical practice?
So some of the key differentiators. So apart from using the Bristol stool chart so that they can really understand the type of bowel movements or the type of stool that they have, that can be a key differentiator to distinguish between which type of IBS they have. It's really going down to symptoms. Sorry, now I'm not sure if I've answered that question correctly.
Okay, we'll see if they pop anything else in the chat, and they can always come back to that. Another question. The low FODMAP diet is often recommended for IBS. Are there any other dietary interventions that have shown similar efficiency in managing symptoms?
Absolutely, and that's a great question, and that is something we could have done a whole presentation on. So I find that the low FODMAP diet is it's quite restrictive. So I use the low FODMAP with my SIBO clients, but it's very important that it's done in a controlled space and it's been supervised, because I find that the low FODMAP can create a lot of disordered eating patterns in clients, and they can become quite anxious about foods, which is kind of a double-edged sword. That, you know, the anxiety around the food could almost be called, it could be psychosomatic as well. So I find doing a specific carbohydrate diet is quite helpful for clients, and that's where you're removing certain carbohydrates, like some of the common ones might be things like onions and garlic, some cases wheat, and seeing how they respond. They're the two generally when you're thinking of kind of, and then the elemental diet as well is also another diet, but the specific carbohydrate diet is one that I use quite a lot with my IBS clients.
Okay, great, thank you. Would you recommend integrating complementary therapies such as acupuncture or yoga for stress management techniques?
Absolutely, and that's actually something I didn't mention, but I put it on the slide for the showing my interventions from cases 3 to 8. She didn't like the artwork as much, and she preferred yoga. So I recommend yoga quite a lot to these clients, just helping with the mind-body connection, and absolutely acupuncture I recommend along with osteopath. These therapies I find, especially when we're working with a case like SIBO, we're looking at things like the ileocecal valve. Now, the ileocecal valve is between the small intestine and the large intestine, and things like osteopathic manipulation can help with releasing the ileocecal valve, which can be really helpful for people with SIBO and IBS. So the thing, yoga as well, and the movement and that connection with the nervous system, yes, absolutely.
Amazing, thank you. And then you mentioned about how there was you excluded some foods from your case study's diet. Were you able to then recommend slowly bringing certain foods back in, or just completely eliminating them altogether?
So I try to encourage a diverse diet, and I really try to encourage them not to be fearful of foods. So I let them direct me in the sense that we obviously do it in a particular strategic way, but for example, I might get them, when we're reintroducing a food, we do it one at a time and we do it in a controlled manner. And when they report to me, and this is generally after we do a lot of the therapeutic interventions, they report to me their symptoms and how they're feeling. I generally get them to pause it and come back to it again, because I want to try and encourage the microbiome to help them tolerate it again once we've got their gut in a good place. But the cross-reactive allergen foods, that one can be different. That's case by case.
Okay, great, thank you. I believe, unless we've got any last minute questions, that was the last of them so far. If that's everything, okay, so thank you everyone, and thank you Jess for your time and your resources and sharing everything with us. We hope that everyone enjoyed the session today.